In not too different vein, we'll talk about ruptures of the long head of the biceps. These tend to occur mostly in older athletes. Typically, it involves the long head of the biceps rather than the short head. And there's usually very minimal loss of function in most people due to an intact short head of the bicep. Again, this can be caused by overuse, which leads to weakening of the tendon and eventually rupturing. It may be traumatic, which can happen with a Fuchs type injury or tension through an eccentrically loaded muscle. A differential diagnosis due to the area of the pain may be a pectoralis major rupture, or sometimes you can consider a distal biceps rupture, depending on the presentation. On exam, you may see the classical Popeye deformity, which is depicted in the picture above. Typically, in large tears or full thickness tears, you will see bruising extensively tracking down from the proximal biceps distally, sometimes tracking a bit across to the pectoralis insertion area. And then in terms of your clinical test, a special test, you may find pain or weakness with speed, so your resistance test. An ultrasound, again, is pretty useful to confirm the diagnosis. You can consider an MRI if there's any doubt or if there's concern about any labral pathology that needs to be ruled out, but usually an ultrasound is a sufficient modality to image these injuries. The treatment, for the most part, is conservative for long head biceps ruptures. Surgical consideration may be considered in upper arm athletes and power sports, all for cosmesis, especially sometimes you see bodybuilders who are quite concerned about the biceps deformity and the bulge of the muscle and may want repair for such reasons. Next up, we'll talk about pectoralis ruptures. This is differential for the previous condition we talked about and vice versa because of their close proximity to each other. Pectoralis ruptures are almost exclusively found in male patients. Typical grading system that applies to most ligament and tendon injuries as far as ruptures may apply here as well, with partial tears being grades 1 to 2 and complete tears being grade 3. Most complete tears, if they occur, will happen at the humeral insertion, and you typically see this pattern of injury in heavyweight lifters, bodybuilders, and such. The mechanism of this is essentially tension created through a maximally eccentrically contracted muscle. And again, with the bodybuilding population, with anabolic steroids being a high risk factor for any tendon rupture, but including the pectoralis tendons as well. Again, the differential will be a proximal biceps rupture with bruising and swelling in the anterior aspect of the shoulder. On exam, besides the aforementioned bruising and swelling, you may find a defect in the pectoralis muscle, which may be visible or palpable, and especially worsened with adduction of the humerus. They usually have a lot of pain and weakness with resisted testing of the pec. The diagnosis in these cases is mostly clinical based on the area of pain, the area of bruising and swelling, and all the other aforementioned features. The ultrasound can be sometimes helpful to confirm the injury, but ultrasound is not a great modality due to the location of the tendon. Its visibility is not great, but also if there's swelling or a lot of bleeding there, this can obscure things quite a bit. So your MRI ends up being the gold standard to diagnose this condition and should be considered if it's going to alter your management approach. Management for most low-demand patients would be conservative, and these would be patients with partial tears, intramuscular, muscular tendinous junction tears. A period of slinging for a short time will be helpful, and then physiotherapy to address strengthening and mechanics of the shoulder girdle. Surgical consideration is useful for patients with humeral avulsion or with complete tendon ruptures, especially in the higher demand athletic populations. Next, we'll talk about AC joint injuries, more specifically AC joint separation, which typically occurs through direct impact to the lateral shoulder or the dorsum of the shoulder. The stability of the AC joint is achieved through the following ligaments in order of increasing importance, or I guess the following structures. We'll start with the joint capsule, followed then by the AC ligaments, and the coracoclavicular ligaments, which are the trapezoid and the conoid ligaments. The most common classification system for AC separation is the Rockwood classification system, which is depicted up above, essentially. So in type 1 separations, you have a sprain of the joint capsule, which is not truly a separation. Type 2, you have a tear of the AC ligament and possible sprain of the coracoclavicular ligament. In type 3 and 5, you have a complete tear of the AC and CC ligaments. In type 3, that can lead to between a 25 and 100% separation of the clavicle from the acromion comparative to the normal side. In type 4, you have AC and CC ligament tears with posterior displacement of the clavicle. In type 5, which is essentially a more severe more severe form of type 3 rather, the coracoclavicular distance is greater than 100% of the normal contralateral side. And then finally, you have type 6, which are full tears of the AC and CC ligaments with an inferior displaced clavicle into the subacromial or subcoracoid position. These are pretty rare and usually result of fairly significant trauma. The differential for AC separation acutely would be coracoid fractures, distal clavicle fractures, or even more medial clavicle fractures with referral patterns of pain to the AC area. In patients presenting with chronic AC joint pain that don't have a history of trauma, you can consider things like AC arthritis or distal clavicular osteolysis. On exam, you will typically find a lot of tenderness around the AC joint. There may be some bruising there. There may be a step deformity visible or palpable, especially in grades 2 or higher. Range of movement is quite severely limited in these patients due to pain. And then you may want to consider doing some of your special tests if the diagnosis is in doubt, such as your Wilkins-Discroft test, which will typically localize pain to the AC joint. The X-ray is your primary mode of imaging in these patients. You may want to get contralateral views to compare for comparison, especially if you're looking at grade 3 injuries or higher. The axillary view may be needed to diagnose type 4 separations, as it best depicts posterior displacement of the clavicle. And then finally, weighted stress views are not typically necessary because they don't add much more to the clinical picture. The management for types 1 to 3 is typically conservative, which includes a short period of sling immobilization. You can consider anti-inflammatory modalities, ice for symptom control, and then rehab to address shoulder mechanics and strengthening. For patients with type 3 who are high demand athletes and have persistent instability, surgical management may be considered. And then certainly for your higher grade injuries, types 4 and above, you may want to consider surgical consultation depending on the level of the patient's function or limitation of function and response to therapy, for example. Next, we'll talk about sternoclavicular instability, which is another condition found on the opposite end of the clavicle. These, again, can be traumatic or atraumatic. Traumatic lesions are usually a result of high energy contact to that area or to the lateral aspect of the shoulder. Atraumatic instability typically seen in the context of generalized ligamentous laxity or degenerative change and osteoarthritic changes to that joint. The differential for acute injuries may be medial clavicle physeal injuries, especially in pediatric patients, or mid-clavicle fractures, and then in more chronic cases, you consider sternoclavicular osteoarthritis. On exam, patients will typically present with pain and decreased range of movement in the area. Most common sternoclavicular instability is anterior, so you'll typically see a visible or palpable prominence of the medial clavicle anterior to the sternum, which increases with abduction or arm elevation. In terms of more posterior instability issues, the concern would be for structures posterior to the clavicle. And so You want to worry about the trachea and the neurovascular structures behind. So in these patients, they may present with dyspnea, dysphagia, tachypnea, or stridor that may be worse in supine position. Neurovascularly, they may present with paresthesia, venous congestion, or decreased pulses in the affected arm. The X-ray can be a difficult way to view some of these injuries, unless you have serendipity views, which can be a bit more helpful. But ultimately, the CT scan is your best modality to image these injuries. Conservative management is indicated in most anterior dislocation subluxations. You may want to consider figure-8 splinting. You may consider steroid injections for persistent pain. You may consider prolotherapy for chronic instability. In terms of acute situations, usually less than 3 weeks, you can try to reduce the joint in a closed fashion. This has been deemed to be less likely to be successful if this is an anterior dislocation. You certainly would want to reduce these if there's a posterior dislocation, especially with any signs of neurovascular respiratory compromise. And ultimately, surgical management may be required in those cases. For patients with ongoing pain or chronic instability, despite conservative measures, especially in anterior dislocation or anterior instability, surgical treatment may involve medial clavicle excision.